It's an incredibly powerful and amazing tool. My feeling about ECG, at least for myself and my own experience, is that I always felt like there was a lot of background knowledge assumed about how ECG is performed. I remember being a medical student and hearing the lecturer talk about the directionality of the ECG and the propagation of the wavefront, and I had no idea what he was talking about. That just seemed like gobbledygook to me. So the purpose of this lecture is not to become expert at interpreting the nuances of every ECG you see, but to give you a framework for understanding ECG and hopefully help to actually clarify some of the mechanical things about how an ECG is formed, which I think is helpful for understanding how to interpret ECG in the long term. So my objectives for you all today are to identify the anatomy of an ECG. I want to explain this concept of wavefront propagation and vector cardiography and what the hell that means. I want to apply that to help us understand ECG, and I want us to develop a framework. So that's hopefully the things I said. By the way, I should have asked, just for fun, any ideas what this ECG is? It's kind of a pattern recognition thing. You've either seen it before or you haven't.
Is it Wellens?
That's a good guess. That's the other differential. Very, very good guess. Brugada, yeah. So Brugada is an inherited arrhythmia syndrome. It's a sodium channel mutation classically identified by this kind of, they call it the saddleback ST elevation in V1 and V2. So it's a fun little ECG. That'll come up again. All right, so anatomy of an ECG. So you've all seen one of these standard 12-lead ECGs, and you've looked at probably most of the numbers here, but maybe not all of them. You've certainly looked at the rate. You've looked at the PR interval, the QRS duration, the QT and QTCs. Axes, maybe. Maybe we've seen those before. P-wave axis, not sure. T-wave axis, question mark. Who knows what that is? We'll talk about that. Does anyone know what this little box is? Yeah. Scale? Yeah, exactly. So what this tells you is these two numbers down here at the bottom. So the width of that, of one box, tells you that the paper speed is 25 millimeters per second. So in the old days, when ECGs were actually printed off, there was those little arms that kind of scrawled on the paper, and the speed that the paper went by the inscriptions told you kind of how wide everything was. And if any of you have ever wandered down into EP Lab accidentally, we look at stuff often at 100 or 200 millimeters per second. So everything looks super spaced out on the x-axis, and that's because we're really concerned with timing of things. But a standard 12-lead ECG in the United States is 25 millimeters per second. On the machine, you can actually change this, which I do sometimes. If I'm really trying to figure out if it might be like a subtle 2-to-1 flutter and I want to increase my resolution on the x-axis, on the 12-lead machine, you can actually change to 50 millimeters per second. But one box wide tells you that it's 25, and then the height of that, two boxes, that's kind of like the volume knob of the ECG. It's called the gain. So standard gain is 10 millimeters per millivolt, but if the patient has amyloid and they have really low amplitude stuff and you want to see it, you can increase that on the machine. And if it's really high, all the waveforms are overlapped, left ventricular hypertrophy, you can crank that down a little bit. What about 100 hertz? What's that? Any ideas? Frequency of the electrode, that's a good guess. This is what's called the low-pass filter. So this filters out noise. Low-pass filter means low frequencies are able to pass through. So everything above 100 hertz is going to be filtered out. That's likely non-physiologic. That's probably noise we don't want to see. And you can change those filters, which is sometimes relevant in a way that I hope to convince you of in a slide or two. So does anyone know what one box is? How many seconds is a box? Big box, little box? 200 milliseconds for a big box, 40 milliseconds for a little box. That's exactly right. Very important. And then how long is an ECG? How much time is conveyed on this piece of paper? 10 seconds. That's exactly right. Now, an important fact about ECG is that everything that's vertical on the ECG is simultaneous. And that's really helpful if you're trying to figure out the timing of something in one lead, but the waveform is not easily identifiable there. You can just draw a vertical line, and you can look at a neighboring lead where the timing might be more clear. So if the QRS looks narrow in one lead, but it's wide in another lead, you know it's really wide, and comparing those two leads by kind of dragging that vertical line of reference can help you really identify the timing of events from one lead to the next. Sometimes you'll see leads or ECGs rather, where each of the leads is the same 2.5 seconds. But that's not that common. That's less common. Most ECGs you see, everything is 10 seconds in sequence. All right. Now, any problems with this ECG? I picked this thinking it was completely normal when I first made this presentation, but I've iterated a few times since then. There's something up. Yeah, what do you think is going on? Kind of a weird R wave progression. What's happening here is that there's actually a cable reversal. So this is actually V1, this is V2, and this is V3. And you can kind of tell that because I focus more on the P wave progression. The P wave in V1 you see there is fully upright, and then it gets kind of flatter, and then by V3 it's fully upright, and 4, 5, 6 it's upright. This was happening for months, and I kept seeing these ECGs with this weird 3-lead swap, V1, V2, V3, and it was driving me nuts. And I eventually figured out that literally the ECG machine in our clinic had the cables plugged into the box wrong. So the nurses were applying them to the patient correctly, and then the cables were getting swapped in the box, and we're systematically producing ECGs with swaps anyway. Okay, so this is the filter I was talking about. So here is a more permissive low-pass filter. Everything below 150 hertz can get through. And you can kind of see it's noisy. It's sort of hard to make out the P waves a little bit. It's not very nice to look at. But if I increase the filter settings to 20 hertz low-pass filter, everything kind of pops out. It looks a little bit nicer. Y'all see how it's kind of easier to interpret with that more aggressive filter? But here's the problem, is that you're actually filtering out information. You want to get rid of noise, but maybe there's some important signals there between 20 and 150 hertz that you lost as well. And I'll show you what one given ECG looks like as I kind of get progressively more aggressive with the filters. So here's 100, here's 80, almost no difference there. You can see like the tops and bottoms of some of the waveforms kind of toggling back and forth here, almost no difference. At 40, you can start to see some more difference for sure. The amplitudes are changing, that's back and forth between 40 and 80. And then at 20, it's like a completely different ECG. And if you put these leads side by side, you have 150, so the more permissive filter on the left, and then the 20, so the less permissive or more restrictive filter on the right. These are totally different waveforms. V2 now actually has a Q wave. You got rid of the R wave entirely by filtering out that frequency, and it looks like there's been an infarct there. Some of the other leads, for example, V6, there was a little J wave, that kind of notch at the terminal QRS at the end, and that's gone away completely. So even though it can be helpful to get a little bit more aggressive with the filters, sometimes you can lose important information and you can get fooled. That's why I sometimes glance at the filter if I just want to know, hey, am I missing some important details? Okay, now this next slide is pretty elementary. I just want to remind everyone, you all know about your ABCs. You learned them in grade school. So it goes P, Q, R, S, J, T. That's the way I learned the alphabet. So I think that's probably what you all learned as well. This is actually called the J point, for any of you that are not familiar with that. And I'm guessing it's because everything got named, and they were like, oh, crap, we want to be able to refer to this thing later. And so that's what it ended up being named. But it is relevant. We talk about the J point from time to time. So just so we're all on the same page about the notation that we're using. Now, the QRS complexes can look a lot of different ways. And you might actually see these stylized way of describing these. So for example, this, although it's a QRS complex, it's just an R wave, right? R means it's the positive component of it. And so there's no negative either at the beginning or the end, so it's just an R wave. And you can still call it a QRS complex, but if you were to write it, you might write it like that. Now this second wavefront, you can see that there's a predominant positive spike, the R wave, and then at the very end, there actually is a little S wave. There's a terminally negative component. And sometimes people will kind of play with the casing of the font to convey a little bit. That's not scientific. That's just kind of colloquial, basically. But you'll see that. So then the next one, you have a smaller R wave and then a bigger S wave. So you can call that an RS. Again, these are all QRS complexes. So you're kind of seeing where this is going. That's QRS. Here's a QR. This one, although it's a Q wave, people will also say QS complex. You don't know for sure if it's the beginning negative deflection or the end negative deflection because there's no positive deflection separating them. So it's just a QS complex. QR, and then what do we call that one right there, that kind of funky looking one? That's right, this is an RS R prime because you have a positive deflection, then it's negative, then a second positive deflection. QR, and then sometimes you'll see waveforms that look like this, where they're just kind of gnarly looking. People will informally refer to this as fragmentation. Normally, the way that the wavefront moves through the myocardium should be nice and sleek through the His-Purkinje system, and there shouldn't be a lot of direction changes. But if you have areas of scar where the wavefront can't pass directly through a scarred area and it has to kind of take a detour around, you're going to get fragmentation where things are going up and down and all around. So that's kind of a soft sign of some myocardial scarring, some fragmentation. Okay, what's this? The first EKG with Willem Einthoven. And this kind of reminds us that which limbs are participating in the formation of leads here? All four of them? No, the right leg is actually the ground electrode, and that's important. Can you imagine how much of a pain it would be if this is still how we got ECGs? And I'm telling you, like, get them every 2 hours. Okay, get the patient down to the basement for ECG. No, but this is the initial ECG by Willem Einthoven, and he has his limbs immersed in buckets of salt water, which allow to record a potential difference across the limbs. And when I think about ECG, there's really two planes that are defined by the various leads. So you've probably seen a picture like this before, and an important bit of definition that sometimes gets confusing is that what is a lead actually? Well, a lead is this thing. It is the potential difference between the left arm and the right arm, with the left arm as the positive pole and the right arm as the negative pole. Now, what's this thing? That's an electrode. It's a patch. It's not actually a lead. The electrode is placed on the right arm as part of the formation of lead 1, but lead 1 is just a mathematical object. It doesn't exist anywhere. And all of us, including me, sometimes use shorthand when we say, you know, the right arm lead fell off, but that's not actually correct. A lead is, strictly speaking, a mathematically derived object. It's a potential difference. And unfortunately, although most things in medicine can be kind of deduced and you can develop frameworks for understanding, you have to memorize this frontal plane. You have to memorize that lead 1 is right arm to left arm, that lead 2 is right arm to left leg, and that lead 3 is left arm to left leg. But I believe in all of you because you've memorized things that were much harder than this, okay? All of you memorized dermatomes. You may have forgotten them, but you definitely knew them at one time. There was a time that you could have told me which amino acids are hydrophobic and hydrophilic, okay? There was a time that you knew the Krebs cycle. There was a time that you knew what a Golgi apparatus is. Who knows what that is? I have no idea. But you memorize that, and you can memorize leads 1, 2, and 3, which you need to do to understand ECG. So again, lead 1, right arm to left arm. Lead 2, right arm to left leg. And lead 3, left arm to left leg. This defines the frontal plane. So this is kind of a coronal plane of the movement of electricity. So if things are positive in lead 1, that's because they're moving toward the left arm from the right arm. If they're positive in lead 2, they're moving toward the left leg from the right arm, and so on and so forth. Now, there's another term that we use that I think is very confusing, which is unipolar electrodes, okay? The leads I just showed you are all bipolar leads, but how do we get AVR, AVL, AVF? What's the negative pole for those electrodes? What is it? Okay, it's theoretical, but do we just tell the ECG think about what a negative electrode might be? Yes, you're getting closer. So the negative terminal of these electrodes is actually the right arm, the left arm, and the left leg all combined and essentially averaged. And that's a mathematical point that puts you roughly in the center of the chest. There's technically, in the way it's done in the back end, you have resistors to attenuate noise and stuff like that. But that's the bottom line, is that it's important to know that each of those 3 limb electrodes is represented in R, L, and F, because the negative pole is really the 3 of them together. So that's how you get the completion of the frontal plane. We had 1, 2, and 3, and then now we have something looking up and to the right. We have something looking up and to the left, and something looking down to the floor. And those are easy to remember compared to 1, 2, and 3. 1, 2, and 3 you had to memorize, but you can remember that R looks at the right arm, L looks at the left arm, and F looks at the floor. Uh-huh.
People who are that double MVT,
Yeah.
how do you establish these?
Yeah, it's a really good question. So what I would tell you is that remember that what you're really measuring the potential across is the heart, which is in the center of the chest. So if you moved the electrode from the right arm, from the wrist to the shoulder, it's not going to look that different because the perspective of that looking at the heart is pretty similar. And you can even move it into the chest a little bit, and it's not going to look that different. And that's why if you have a reversal between the right leg and the left leg, you would never know that on ECG because they look identical. The both of them are looking up at the heart, and the right leg sees the heart right over there, and the left leg sees the heart right over there, but they look pretty much the same. So you can, for convenience, put the electrodes actually on the torso closest to where the designated limb would have been. Very good question. Using this, you can start to see some of the territories. So we call 2, 3, and F, we call these the inferior leads because they're all looking downward. 1 and AVL are some of the lateral leads, right? They're looking up and to the left. And so that is the frontal plane of the ECG. Does that make sense? All right, now we've got a second plane to look at. Fortunately, the second plane is easy and doesn't require much memorization at all. This is the transverse plane. So we're looking at the frontal plane here. This is our transverse plane here. All right. And so what do we have? We have these 6 electrodes, very conveniently numbered from right to left, V1 through V6. The reason I display this image is because I want you all to remember that even though V1 and V2, they seem so anterior. They're like right on the front of the chest. But remember, the heart is not in the Valentine position that you've seen it drawn, where like the left ventricular apex is down at the feet. It's actually tilted off into the left side in the body. So even though V1 and V2 are anterior with respect to the body, they're actually quite rightward with respect to the heart, and they're really right ventricular leads. That you get a lot of information about the right ventricle, actually even out to V3 and V4 sometimes, because many hearts are rotated even more, and the right ventricle is the most anterior chamber, so you're going to see a lot of right ventricular information in those leads. But then we just sort of divide these. We call these septal, we call these anterior, and we call these lateral, and those are just kind of soft terms to describe this stuff. Now, the placement of these is actually really important, and I'll tell you why. This was a study done of healthcare workers where the investigators had the healthcare workers apply electrodes to the patient's chest, and then they actually constructed a heat map showing where the electrodes ended up and where they were supposed to be. And in the center of the circle is where the electrodes are supposed to be, and then each concentric circle is like a couple centimeters, I forget how much. So this one up here, that's like up on the right earlobe. That's way far away. That's nowhere close to where V1 is supposed to be. There's this couple there, that one on the D ring, that's like down on the belly button. So this is more often than not, I find, they're actually not placed in the correct location. The correct location for V1 and V2 is in the 4th intercostal space, which is basically between the nipples. Now, why does this matter? Okay, I was on call one night, and I got a call from the ER, and they said, we got this young guy here. He had syncope. It's a really concerning story. They say he's got this kind of incomplete right bundle branch block thing in V1. We think he might have Brugada. And that's the call I got in the middle of the night. And I said, well, it doesn't really look like Brugada. But even more importantly, I know for a fact that these electrodes are misplaced because the V1 and V2 P waves are completely upside down. Remember, V1 and V2 are meant to be over the atria. So if they're upside down, that means you're way up here looking down on the heart. And of course, all the electricity that you see, the depolarization of the atrium, everything's going to be away from you. It's very far away. What you should see is that V1 should be over the right atrium. The right atrium depolarizes positive. Left atrium in the back of the heart depolarizes negative. You should see a biphasic P wave in V1. And by V2, it should be fully upright. So I went to go see this guy. And that's where his electrodes were. They were so high. And he had the ironic tattoo and everything. Just unbelievable. And so I said, well, I know how to fix this Brugada syndrome. I'm going to replace the electrodes where they're supposed to be. I probably put V1 a little bit too low in my zeal, but you get the point. And then I repeated it in ECG, and all of a sudden it was gone. So I would say V1 and V2 placement, very common, super, super common to see them way too high. And part of that is that people come into the ER and they may have like defibrillation patches and stuff, and so they may get put in weird places, but just be mindful that little changes in the placement of those electrodes can produce some surprising results. Okay, so we've talked about 2 planes, now we put it all together. You've got a 3D area of space where you can see the activation of the myocardium. You kind of group these here inferiorly. You've got the septal leads, the anterior leads, and then the lateral leads. And sometimes, the only thing I don't like about this illustration is that lead 1 is drawn here in the center of the thorax, but it actually goes up to the left arm. Sometimes people call these high lateral leads. That's just kind of a colloquialism, take it or leave it. But if you hear people say high lateral, they're talking about the limb leads because V5 and V6 go to the mid-thorax. That's where the electrodes are, whereas 1 is actually on the left shoulder. Does that vector cardiographic, does that make sense? When we have positive deflections in a given lead, that means that the current is traveling toward the positive terminal of that lead. Seeing some nods, no one's crying and walked out yet, so I think I'll take that as a good sign and I'll move on. And then someone thought, we need to put this in a way that makes a lot of sense on the ECG. Let's group everything, oh, yikes. So, not the best, but we learn to live with it. There are other formats of the ECG that make a little bit more spatial sense. There's something called Cabrera format, which is more of a clockwise representation, but we got what we got. This is North American, where it's probably not going to change. Okay, so why does understanding the formation of the electrodes matter? Why did I waste your time with that? This is a call I got. This is an older woman, 80, 85, came in with sudden onset dyspnea. And they wanted to know, is this actually, is she having an MI? She's got these huge, enormous T waves in 1 and AVL, huge negative T waves that look like reciprocal changes in 3 and F. The chest leads are kind of wacky. Lead 2 is not as weird looking, looks kind of normal actually relative to the other stuff. What might be happening here? Any ideas? I'm seeing things I like, movements to which arm is the thing, and yeah, I love that. So I'm going to show you a diagram that I hope explains this a little bit better. So this is a friend of mine, Aaron. He's an incredible ECG interpreter. In the UK, his training is he's a nurse, which in his scope of practice there, he does ECG interpretation. He's almost as good as anyone I've ever met. He's incredible. And he made this really cool diagram. So you imagine these are your electrodes, and if you shake the right arm electrode, notice that all the leads are distorted except for lead 3. Lead 3 doesn't involve the right arm electrode in its math. Each of those 3 limb leads, 1, 2, and 3, each of them, they're the only leads on the entire 12 lead that lack information from one of the limb electrodes. And so what's happening here? On hers, lead 2 is kind of normal. So lead 2 is, let's think about it, right arm to left leg. So those leads have to be fine. Those electrodes, I caught myself, I said leads. Those electrodes have to be fine. So it has to be that left arm electrode that's messed up. I went to go see her. It was overlying a dialysis fistula. So this is actually called arterial pulse tapping artifact. That's why you get this cyclical deformation. Each time she has a heartbeat, it kind of messes with the dialysis fistula. And I moved that electrode, and then she had a much more normal looking kind of AFib paced ECG, not that weird. Alrighty. Was there a question? Okay. All right, so I'll move a little bit into my approach. You've probably seen these before. There's nothing novel about the way I do this. I like to go rate, rhythm, axis, hypertrophy, intervals, ischemia. I think everyone agrees rate, rhythm, axis, and then it's kind of dealer's choice what you do after that. This is my own internal framework, works for me. I try not to miss stuff. Frameworks are important in internal medicine, as you all know. So for rate, there's probably a couple different mechanisms you guys have learned. You've learned 300 divided by a number of big boxes, right? Because there's 60 seconds in a minute, there's 0.2 seconds per box, whatever. You get the point. For this one, it's very helpful, I find, just for at a glance looking at an ECG. And I've done it so many times that I memorize these numbers. 300, 150, 100, 75, 60, 50. If the spacing is fewer than 3 boxes, I already know it's fast. If it's more than 6, it's slow. You can tell that by the eyeball. But these are good benchmark numbers for me to remember. Of course, that really only works if you have regularity of the heart rate. If it's irregular, you're going to get misled. So you've also learned you count up the R waves and multiply by 6. Standard ECG is 10 seconds. So the easiest way, I think, in practical terms to do the big box counting method, which I like a lot, is to try to find a waveform that falls nicely on a big line. So like that one right there, you can, just falls nicely on that line. You go, okay, it's clearly more than 3 boxes, just a little bit more. So this heart rate's going to be a little bit less than 100. And I'll convince you that this matters and it's not just a dumb exercise we're doing, because I know the rate prints out on the ECG, but it's not always correct. So just over 100, and then I'm confident you all can count to 15. Get that, 90? Okay. So that's rate, and I have another slide on that. Now rhythm. Okay, I'm doing 2 years on this, right? I can't tell you everything. I would be out of a job. That's no good for me. But I will share with you one secret today. You're all going to leave the room, and I want all of you to be able to identify sinus rhythm on ECG. So I'll give you a sample ECG, and I want you to tell me what is the rhythm. And I'll let you look at it for a little bit. I'll give you a little hint. What do we think? Is it sinus? People usually tell me sinus rhythm is when you have a P before every QRS and QRS after every P. Have you heard that before? What is sinus rhythm? Someone tell me what sinus rhythm really is. Not in EKG, but just in general. Beautiful, beautiful. Sinus rhythm is a rhythm which originates in the sinus node. So how would we figure that out? Well, the sinus node is in the top right corner of the heart. So when it sends out depolarization wavefronts, they're going to spread away from the top right corner of the heart. So lead 1 is right arm to left arm. Is the sinus going to be positive or negative in lead 1? Positive. Lead 2 goes from right arm to left leg. Is the sinus going to be positive or negative in lead 2? Positive. AVF goes to the floor. Is it going to be positive or negative? Positive. And then lead AVR, which looks up and to the right, what's that going to do? It's going to be negative. Yeah, it's coming right at me. I'm looking that way. My positive end is that way. Sorry, I said that confusingly. But it's going to be negative in AVR. So on this guy, what do we have? Lead 2, they're upside down. Lead AVF, they're upside down. Kind of flatten some of the other leads. This is some kind of low atrial rhythm. Now, it has a 1-to-1 conduction. There's some ectopic focus somewhere, maybe near the coronary sinus or something low in the atrium. But this is not sinus rhythm, even though there's 1-to-1 AV conduction. Other ectopic things can still drive the ventricle. So that 1-to-1 is kind of a critically flawed heuristic, which will lead you astray at times that are really important. I'll give you another example. Someone tell me what the rhythm is here. And I left the attending read on, in case that's helpful to you. So complete heart block, that's written down. That's the state of the AV node, but what's the rhythm, though? I heard someone say P waves. Okay, what do we think of the P wave morphology? Sinus, non-sinus? Sinus. This is sinus rhythm. The P waves are upright in 2. They're upright in 1, they're upright in F, they're upside down in AVR. They actually have that nice biphasic appearance in V1 that I told you about. And importantly, this is not just sinus rhythm. This is actually sinus tachycardia. The EKG machine didn't tell you that. It told you that the heart rate was 29. What I see when I look at this ECG is a patient that is not doing well. Many patients in complete heart block, and you may or may not have taken care of them yet, but a lot of them are fine. If they're at rest in bed, they don't feel much of anything. They may say they're a little lightheaded. In fact, I had a guy come in maybe a month ago who had probably been in complete heart block for 3 or 4 months, and he was still hiking. Like, he was doing just fine. So most people with complete heart block can do fine. They probably have exertional intolerance, and there's variable degrees of symptoms. But what tells you how they're tolerating it, at least in part, is what the sinus node is doing. No one told the sinus node that the AV node stopped conducting. So the sinus node is still connected to your nervous system, and the fact that her heart rate is 117 tells you that the brain is asking for more cardiac output. So you know that she's going to be someone who probably needs a transvenous pacemaker while she's awaiting permanent implantation. She's not tolerating the hemodynamics of complete heart block very well at all. So what I would say here is that the actual interpretation of this ECG is sinus tachycardia with complete heart block with ventricular escape rhythm. There's 2 rhythms happening here. There's the atrial rhythm and the ventricular rhythm. There is no left bundle branch block. There is no left axis deviation. That's just the ventricular escape rhythm. So that's why that morphology stuff matters. That's why reading rates matters, because the EKG machine is just going to give you one rate, which is probably the ventricular rate. That may not be the only rate you care about. All right, axis. You've heard about axis. What is it? How do you figure it out? Well, I think that the painful part of learning the leads actually helps with this part. I've heard a lot of different ways to read axis. I think my way is the best. I know that comes as a shock probably. But I look at leads 1 and AVF first, which gets you most of the way there. Yeah, that's the other way I've heard. I've never understood it. The whole handshaking, thumbs up, thumbs down. Maybe you can explain it to me later. I think my way is easier. Occasionally, I have to look at lead 2. And then if you have an axis deviation, that's your trigger and your diagnostic schema to ask yourself or wonder whether there might be a fascicular block. Fascicular blocks may or may not be important to recognize for the most part, but they, if you're someone who cares deeply about ECG, first of all, it can be some evidence of conducting system disease, and so that might help your diagnostic schema. Someone comes in with syncope, things like that. But the way to identify a fascicular block is to first notice axis deviation, which is a prerequisite for fascicular block. And left anterior fascicular block is actually really common. Posterior fascicular block as an isolated finding is pretty rare, but sometimes you see it with right bundle branch block. Oops, my bad. And in case you forget the criteria, you can just look it up, super easy. But you have to think to look it up because you've noticed an axis deviation. Okay, so we had this thing. Does this image make sense? Anything unclear about this image? All right, now I worked longer than I care to admit to make this beautiful animation, so I'd really appreciate it if you all appreciate it. So we're going to go from that. And we didn't actually change the orientation of any of the vectors. We just kind of moved them. Yes, thank you. Thank you. Yes, thank you. And then that's how we get, we can do it one more time. I mean, you know. But this was very unclear to me for so long when I looked at this image. And I just want you to understand that when we go from this thing to the circle, we didn't change the orientation of any of the vectors. We just slid them in a way that makes more sense to our eyes when we're looking at them. Get rid of it, and then reformat it. Yeah, and now it makes a little bit more sense to me than this weird triangle thing to imagine looking at the frontal plane. Magenta, or whatever color that is, that's kind of the normal area. Blue, this cyan, is right axis deviation. That green is left axis deviation. And then sometimes people call that northwest axis, which is weird because everything else in medicine we say from the patient perspective. That's like looking at the patient. But you could also call it extreme axis deviation. It's extreme because you might have been super far left or you might have been super far right. But either way, your axis is on the complete opposite side. Okay, so you look at lead 1 and tell me, is lead 1 mostly upright, QRS, or mostly upside down? Mostly upright. Lead AVF, same question. Upright. So now we go back here, and we go, OK, lead 1 was upright. So we know the wavefront is traveling toward the arrowhead of V1. That eliminates from contention that half of this circle. The axis can't be over there, because lead 1 was positive. It'd be negative if it was over there. Does that make sense? Then you say the same question for AVF. AVF was positive, so it's traveling toward that arrowhead. Boom, normal axis, done. OK? So here's another one. Lead 1, mostly positive or mostly negative? Negative, that's right. Lead AVF, positive. So we go back here. OK, we said 1 was negative, so that eliminates the kind of left half of the circle from contention. I'm using patient anatomy here. And then we said lead AVF was positive. Boom, right axis. I didn't have to put my thumbs in the air or do anything. I just looked at it, sorted it into quadrants. OK, here's another one. OK, lead 1's positive. Lead AVF, negative. So then we go back here. We said, OK, lead 1's positive, so that eliminates this part. Lead AVF was negative, so is there an axis deviation? Maybe. Maybe. We might be in magenta, which is left-ish, but normal. We might be in green, which is very far. That's left axis deviation. So which lead do we need? That's right. You guys, I'm so proud of you all. Normally when I give this, everyone says AVL. It's like it's staring you in the face. It's right there. But that doesn't help you. AVL, like that's not helpful. It's either, it has to be positive because you've eliminated the other areas. But what you need is lead 2. Lead 2 tells you across this perpendicular, where are you? So we look back at it. We go lead 2, positive. OK, great. Normal axis. We did it. Here's another example, just for practice. Lead 1's positive, F's negative, 2's negative. OK, so that 1's positive, F's negative, left axis deviation. That's actually a left anterior vesicular block. I think I have like one more here. OK, so lead 1, negative. Lead AVF, negative. All right, we're in this extreme territory, extreme axis deviation. All right, rate rhythm axis, hypertrophy. OK, hypertrophy. So as a proposition to set out at the beginning, ECG is not sensitive or specific for LVH. But there are still some things that are worth learning about it. So for one, for test taking, when you're on boards, you have the overlap waveforms. That's typically how you're going to identify it. In real life, I think the simplest criterion that's pretty easy to remember and has actually quite good specificity is the R wave height in AVL. The sensitivity is terrible. But if you see an R wave in AVL greater than 11, that is pretty specific. There's a zillion criteria. It's not worth memorizing them. I memorized them for boards and then promptly forgot them. But what I do want you to know is that left ventricular hypertrophy makes ECGs really ugly. You get profound ST elevation, ST depression, ugly repolarization, all that kind of stuff. And the classic finding of left ventricular hypertrophy, and we call this the repolarization abnormality, is infralateral ST depression and often T-wave inversion as well. So I'll show you some examples just to kind of make the point so you know what it can look like. Here's an example of an ECG. This, for example, doesn't have R wave height in AVL. That's very big. I'm sure it meets other criteria. But you can see that in leads 1 and V5 and V6, and in the inferior leads, there's a bunch of ST depression, T-wave inversion, not ischemic. This is a baseline ECG for this person. This is just left ventricular hypertrophy with repolarization abnormality is how I would describe that. If you, in our reading software, you can actually separate out the waveforms so you can really appreciate the full, that's the same ECG, it's just easier to appreciate the full height of the R waves there. All right. Now, I told you that the gain is kind of like the volume knob of the ECG. And remember that you're measuring myocardial depolarization. So if you have a lot of left ventricular mass, like the volume's way up. There's more myocytes shouting at you about what's happening in the world of depolarization. So you can just crank that volume knob back down. You see the height on that little thing on the left side got a lot shorter. This is 2.5 millimeters per millivolt. So this is quarter volume. And it starts to look more normal, by the way. You don't see as much ugly stuff because I've turned the volume down to accommodate for the enormous left ventricular mass. Here's another one. People look at this, they're like, oh my gosh, there's so much ST elevation in V3, V4, is it a STEMI? There's reciprocal depression. Nope, this is just LVH. That's all it is. Bland LVH, there's no superimposed ischemia, just LVH. Very, very ugly. Turn the volume down, looks a little bit more normal, same ECG, 2.5 millimeters per millivolt. Same thing, tons of ST elevation. What, there's 4, 5, 6 millimeters of ST elevation, V1, V2, V3. That's just LVH. This one, this was activated as STEMI, just bland LVH. This one, this was activated as STEMI. I went to go see him, he was sleeping, by the way. Pretty strong negative predictive value. I don't think I've ever seen a sleeping myocardial infarction patient. And then just one more just to kind of make the point. So I just want to show you that it can look a lot of different ways. It can distort the ECG. And if you call me and I'm like, nah, that's just LVH, you know that I'm not making it up. It just really does make the ECG look weird and ugly. So we're on to intervals. So what do we have for intervals? Well, the PR interval, we've got that here. Onset of P to onset of QRS. What's normal? I'll assume someone said it correct. All right. So that's about 120 to 200, so 3 to 5 little boxes, which is helpful. The QRS, what's normal? 120, that's right. Onset of Q to conclusion of S, so the entire thing in the widest lead you can really measure it in. And that's 3 boxes, technically 110 if you really want to be pure, but that's a little bit ticky-tack. And then the QTC interval, so that's onset of Q to conclusion of T. How much is normal? Not totally clear. Women seem to have a little bit longer QT intervals than men. I don't think anyone really knows what normal is. I at least don't. But why do we care about the QT interval? What's the thing we're worried about? Torsade. It's like the torsadometer, right? If you have a super long QT, you have a repolarization when it's partially refractory, and you end up with torsades. So probably the thing that most internal medicine people care about is what's the ondansetron safe limit. So I'll just give you a kind of a round number to think of. Just to remember, that's not evidence-based, that's not science, that's just general advice. Less than 500, it's going to be fine. Okay, now bundle branch blocks, I think, are helpful to learn. And by the way, in the context of bundle branch block, it's a lot less clear what a normal QT is. I won't go into all the details of that, but you can get, because the QRS is so much prolonged, the QT as a whole prolongs, even though it may not indicate that there's that much risk of torsade. So with bundle branch blocks and how you identify them, the thing to remember is that when you have aberrant conduction that's not going through the His-Purkinje system, it's big and slow. It makes a big footprint on the ECG. So the terminal depolarization of leads 1 and V1 tell the story, and I'll explain why that is. AVL and V6 can be helpful. So we have our little guy here. We have lead 1 that went from right to left, so that's a leftward lead is V1. We talked about how V1, even though it's kind of anterior, is really a rightward lead. So when you have bundle branch block, the non-blocked bundle depolarizes first, right? You have left bundle branch block, so the right bundle branch is doing fine. After the right bundle branch depolarizes, then later, the area of the blocked bundle depolarizes. It's not like that part of the heart never depolarizes. It's just a lot slower and with a big muscle-to-muscle conduction. So blocked bundle depolarizes last, and therefore, the second half of the QRS is showing depolarization toward that area. It's the last thing to depolarize. So the direction of travel of the current in the second half, if you'll indulge me with that idea, is toward the blocked bundle. How does that look in practice? Well, you take this ECG right here, look at lead 1. The terminal portion of the QRS, is that positive or negative? It's negative. So it's traveling to the left or to the right? It's traveling to the right. Lead 1 points to the left. Negative means it's going to the right. Okay, and then in lead V1, the terminal QRS, is that positive or negative? It's positive. So that's traveling in which direction? To the right. So that gives us concordant information. Both these tell us that the terminal depolarization, the blocked bundle, must have been the right bundle. You can see similar stuff in AVL. AVL is a little bit terminally negative, so it's going away from AVL. It's going to the right. V6, a little bit terminally negative. It's going away from V6. It's going to the right. Okay, then you see this one. I show you these. You may recognize the easy, obvious ones, but the point is that sometimes bundle branch blocks are atypical, so this is, I think, a useful framework to think about it. So in lead 1, the terminal QRS, is that positive or negative? It's positive, so current is traveling to the left. And in V1, the terminal QRS is positive or negative? Negative. A big part of the QRS, that's all still negative, so that's going away from the right, so it's going to the left. So the last thing to depolarize is the left. See the same thing in AVL, see the same thing in V6. That must have been left bundle branch block. All right, we're most of the way there. We're on to ischemia. This is my second favorite topic. I love rhythm, but I love ischemia too. I can't give you all the secrets, or I wouldn't have any more lectures to give. So I'm just going to tell you, if you care about reading ischemia, I strongly recommend reading Dr. Smith's ECG blog. It is the single greatest source on planet Earth for understanding ischemia. It is free. He's been writing posts since like 2005, maybe. Really long time. There's an unbelievable amount of information there. I want to give you a little taste. So I'm going to show you 2 ECGs, and I want you guys to tell me which one of these 2 ECGs represents acute coronary occlusion. So I'll show them to you both, and then I got them side by side for you. So here's one of them. Here's another one. All right, now, side by side, which one do you think represents acute coronary occlusion? Losing trust in the presenter. The bottom one says acute MI STEMI on it. Well, it depends. Is it like 2 p.m. on a Tuesday? That's a good time for a STEMI. Is it like, Christmas Day? No, that's not a STEMI. The answer is the top ECG represents acute occlusion of the LAD. The bottom ECG is actually normal. Everyone was convinced this guy had pericarditis. He got 1 million rounds of colchicine. His cardiac MRI was normal. This is an uncommon normal variant. It's called benign T-wave inversion. By the way, do you see how big the R wave is in V4? This is an ECG that was handed to me in the ER. I'm not pulling any punches on you. They said, oh, you got a STEMI, and they handed it to me, and this is what they printed out. But it goes to the top of the page. That R wave is enormous, huge voltage. So if you think about it, that amount of ST elevation is basically trivial compared to that. No chest pain. Oh, no, actually, I take it back. He did have chest pain. And and he got a cardiac MRI that was normal. He had serial troponins that were negative. The cardiac MRI read even went so far as to say no evidence of pericarditis. And by the way, this guy's ECG looks the same every time you see it. It's been the same for many years. That's his ECG. That's how it looks. He's a normal heart. ECG can be really subtle, and understanding ischemia is not as easy as they may have led you to believe. I think this is probably the single most important image that I feel was never shown to me, which is the dynamic nature of acute coronary occlusion. It's not just this fixed thing where like they're at home, they get a STEMI, and then it just stays right at that 1 millimeter cut point, so nice of the human body to obey the metric system. The first thing that happens when you get acute coronary occlusion is actually the development of hyperacute T waves before any ST elevation. Hyperacute sounds like it should be really obvious because, hey, they're hyperacute, but it may not. Hyperacute refers to the time course. That's the first thing that happens, often within minutes. If you retain that occluded artery, you're likely to develop ST elevation, but that's certainly not guaranteed. But any given time, your body can spontaneously break down that clot, and you may have reperfusion. You've heard about Wellens. Wellens is just reperfusion of the LAD territory, where first you get terminally inverted T waves. They call that Wellens pattern A, and then over time, with persistent reperfusion, you can get Wellens pattern B. But it's really a dynamic thing. And I just want you all to have seen this image to understand that if someone has T-wave inversions in general, okay, I don't know, that may or may not be meaningful. It can be nonspecific. But if someone comes in and tells you, oh, I came in because I was having terrible chest pain, but I actually feel a lot better now. And they have new T-wave inversions. Now that is a concerning finding, and that fits with recently reperfused, but probably still high risk acute coronary occlusion. General principles of ischemia, this is like my last slide, I think. Proportionality, super, super important. The body does not actually care about millimeters. You can't name one disease that is defined by a metric cut point. We told you that acute coronary occlusion was, but that's not true. Proportionality is more important. The J point, the ST segment, those are not the most important things. It's actually T waves, in my view, that are the most important finding, although it's really the whole ECG, of course. And for you all, history is the most important finding. If someone tells you a story that sounds like they're having an MI, get me on the phone, you know? Even if you don't think that the ECG may look that concerning, it could be this one on top, which is diagnostic for LAD occlusion. But she made it easy. She came in with crushing chest pain that was, unrelieved by everything else. It was radiating into her left arm and all this kind of stuff. So history is the most important finding. I think that's the take home for you all. So in conclusion, please memorize leads 1, 2, and 3. Save yourself memorization later. Use the vector space to deduce important information, and just come up, it doesn't have to be my strategy, but come up with some strategy so you're systematic in your approach. And I think that's everything I have right on time. Any questions?
Is this sort of an elementary question?
Sure.
When they say you did arm leads,
Uh-huh.
you had the razor arm versus the
Uh-huh.
side where it is, does that change the appearance of the ECG?
That's a good question. My feeling is that it may a little bit, because as you move, you're going to deform the contents of your thoracic cavity a little bit, and so it may shift the heart. You can see, for example, there's respiratory motion often. Not always, but often there's respiratory motion on the ECG. Sometimes if someone's really tachypnic, you can actually kind of guesstimate the respiratory rate based on the undulations you see. So those types of things can make small differences in the ECG. Especially if it's overlying a muscle, by the way, because then you get myopotentials too and other stuff. What were you going to say?
But I guess it's just like basically the armpit, it's like where the sort of electrode essentially is.
I like to move it around. I'm going to say that I've probably personally obtained more ECGs than most people. And so what I do is I'll usually start at the wrist, just because I'm sort of a purist and I feel like it's the limb lead. That's the way Einthoven did it, but there's no evidence for that. That's just my opinion. But if I get a bad reading, and if I'm getting a bunch of artifact and I think I might be over a muscle or something like that, I'll move it and I'll maybe inch myself up the arm or try to find just some place that I can get the clearest reading, knowing that anywhere kind of on the arm up to even really here is going to be pretty much similar, because the heart looks the same from all those different places. Does that answer your question?
So it has to travel through the body. It's like when you move the arms like this, that shouldn't change.
Correct. Yes. No. No. Totally fair question. No, that shouldn't change it. Awesome. Yeah.
So the negative lead for